we enjoying the conference? Good. Did you, anybody go to the keynote this morning? Were you there?
Yeah.
Oh, good. Enjoy her. She's so good, isn't she, Temple? I've listened to Temple, I don't know if you have, over the years, and I've never seen her so relaxed than she was with Marty, because they're such good friends. So you could just tell that she was much more like in her element, being able to be her authentic self, which is so nice to see. So she's just awesome. But we want to thank PRN for sponsoring this morning's session with Gastric Dilatation and Volvulus with the one and only Dr. Shadi Arafij, and he'll go over some of. Did you put your resume up on here?
I was going to say.
Okay,
you know,
yeah, it looks
a template.
Pretty damn. But yeah.
It just happened to be there.
Yeah.
Otherwise, I'll do it.
But no, he'll tell you more about himself. But he is a very good dear friend of mine. I'm proud to call him a friend. Our profession is blessed to have him in this profession. He's just a great guy. He's on our editorial advisory board here at dvm360, and he's an international speaker. And he's, again, just a person. What I love about this guy, honestly, is that he's a text or an email away. So if you get stuck on something or you send him pictures and you just don't know, no judgment. He will help you and walk you through anything. So please give him a nice warm round of applause for Dr. Shadi.
Thank you.
You're welcome. You can just Venmo me later, okay?
You got it, brother. Good morning, everybody. Thanks for waking up and coming by. So this is always a fun topic. It's such a common disease. And just by a show of hands, how many folks here cut these cases? Yeah, all right. So we got pros in the room. So if you have any different experience levels with what I'm saying or any disputes with what I'm saying, please feel free to jump in to open forum. We can talk about anything you want. I won't be offended by anything. There's many different ways of handling these cases. They're so complex, but they're also rewarding. They can be rewarding too. So for those who don't know me, I am Dr. Shadi Arafij. I'm a boarded surgeon, and I graduated from Kenneling University in 2006. I then performed my one-year general internship at Angel in Boston. That was a rough year. After that, 2 one-year surgical internships at Long Island Veterinary Specialist, and I ended up staying on as a resident. After I was there for maybe 9 years or so, I then moved out west to Las Vegas, worked at a specialty hospital there for about 9 months. After that, I toured the country as a locum, just relieving other surgeons so they can have some time off. And then from there, I went to Silicon Valley, where I managed 3 hospitals for United. So I was on call 24/7 for 3 locations. That was a bear. And then after that, True Care for Pets in Studio City, LA. I was part owner of that hospital, managed all the specialty departments, and now I operate Vet Triage full time, which is a virtual platform that I'm happy to talk about if anyone's interested. So we're going to go through a whole bunch of information here. Obviously, GDV is a very complex condition, even though it's so common. Again, the preceding notes, if you don't have them, when you do receive them, they are insanely detailed compared to what we're going to go through. This will be purely practical, clinical, so I want it to be applicable to your daily lives. We'll go over the prevalence of GDV, the risk factors, etiology, pathophys, symptoms, diagnostics, stabilizing the patient, treatment, surgery, complications, outcomes, and any questions you have at any time, feel free to shout them out. It's a very common disease, and part of the challenge with conditions like this, when you're performing a literature search to try and give you sort of the academic overview of this, every study is all over the place, because every study is different in how they construct it. There are good studies and bad studies, and so it's tough to kind of take the information out there and sort of compile it into one succinct format for you to be able to digest in a timely manner. You're all busy people. And so some of this information, it can vary depending on what you read. But in general, the incidence of GDV, 2.4 to 7.6 for every 1,000 dogs admitted to the hospital. So it's quite common. A slight predisposition towards males. They're usually middle age, although theoretically any age can be affected by it. They tend to be larger sized dogs, obviously, but again, I have seen it in small and medium sized dogs as well. And there are, of course, predilection for certain breeds. It's your classic large breed or giant breed dogs, deep chested, obviously, but it can be in any breed, theoretically. And I think there have been reports in other species as well, but most commonly it's a canine condition. German Shepherds are 12%, Great Danes, standard poodles, but your standard breeds. How many folks here have seen GDVs in medium and small breed dogs? Yeah. How many have seen them in non-canine species? Yeah. I know there's at least one report on a cat, and I think kids get them too, but There's a list of other animal types in the notes. So risk factors, there are a ton, and these risk factors can be, considered maybe relevant or maybe just sort of consequential. Like, who knows? There's sort of just an association, but no real connection. So you have to be able to flesh out what really matters when you look at risk factors, because there's a lot of them. And so I picked kind of the more important ones for us to care about. But keep in mind, again, just because there is a trend with something doesn't necessarily mean there's a real causality there. It just happens to be that enough animals had that in common with this disease that, maybe that's a risk factor. And whether it's realistic or not, or practical or not, is another story. So advanced age, we definitely see it more so in the middle age to older dogs. Obviously, large breeds. A low number of meals per day may play a role with this condition. Temperament, those dogs that are a bit more anxious, more high-strung, tend to be predisposed to GDV. Ones that are a bit more happy-go-lucky are less likely so. Family history of GDV, for those who have that record, that's not really a common history in our profession, but if you do have that history from like a breeder or something, then that plays a role as well. A splenic torsion, whether it be in the past or currently, makes them more predisposed to GDV. The question with that is, whether that's a breed-related thing. I've only seen maybe 2 splenic torsions in my 17 years, and they were both English bulldogs, which is the classic breed to get splenic torsions. And I don't really see a lot of GDVs in English bulldogs per se. So, is this a matter of breed-related, or is it a matter of ligament laxity in the body that predisposes the organs in general to torsion? Maybe. Or is it a matter of dogs that have splenic torsion in their history and therefore splenectomy are more likely to have GDV? And we do know there is a risk factor there. 3 to 8% of dogs with GDVs had a history of splenectomy and have a 5 times risk for developing a GDV. So then that begs the question, of course, and this is a topic that we discuss usually in my hemoabdomen talk. Do you PEXI dogs that have a hemoabdomen or a splenic mass or undergoing splenectomy for any reason? And so, do you or do you not? But one reason to PEXI them, theoretically, at the time of splenectomy is to prevent a GDV later on. So, and you could, of course, make the argument, well, what if the patient is unstable? What if the patient is geriatric? What if they have hemangiosarcoma? Is it worth the expense of the owner? Is it worth the anesthetic time? Is it worth putting that patient through a PEXI in that scenario? And so I don't know. It's up for debate. It'd be a fun thing to talk about. But anyway, we know there's a predilection there. If they have a gastric foreign body, maybe more likely for a GDV. I haven't seen that many foreign bodies at the time of GDV myself, but they always have like a large amount of food and water in there, right? But I haven't seen too many foreign bodies, but there is a 5 times risk of developing GDV, and then being intact also might be a factor. And there's a ton more, and some are just silly, and others are maybe relevant, who knows. So the etiology, the question is, do they bloat first, or do they have volvulus first? What comes first? And I don't know, and who cares, probably. But if you're interested in that kind of thing, there's theories on both aspects. And maybe it depends on the cause. Maybe those dogs that develop a GDV after they've just eaten and then ran around, maybe that's more of a volvulus thing, because now you have this big heavy stomach that's swinging in the abdomen, and they're running around, and now it has volvulus and then GDV. Maybe that's the case. Or maybe there's a motility issue with these dogs. Maybe they have either a neurologic motility issue or a gastric muscular motility issue, and they are more likely to bloat because of gastric atony, gastric paresis, right? Maybe poor motility. So I don't know, but one of these things happens first and then leads to the other. And then whether or not GDV is acute or chronic. So I have a theory that there's a subset of dogs out there that I call chronic bloaters that will tors and then detours on their own. Because sometimes when you interrogate these pet owners about the history more thoroughly, sometimes they depicted signs of GDV in the past, and then it sort of self-resolves spontaneously. And we've all had dogs probably that have walked to the clinic with a GDV, and they're completely fine. They're stable, just a big belly. It's a GDV, but they don't have that cardiovascular hemodynamic instability that you typically see with a GDV. So what's up with that? And I've also had dogs that as I'm performing the surgery, detoursing them, as I'm trying to PEXI them, they're literally actively trying to tors again in surgery. It's just the stomach keeps swelling up with gas and keeps trying to tors on me. So I'm convinced there's a subset of dogs that I call chronic GDV dogs. Obviously, there's no evidence for this, it's just my own experience with it. But just keep in mind, you can have a very stable GDV walk in the clinic. I've had a GDV actually that somebody performed a CAT scan on. Came in for gastric distension. I don't know what diagnosis they did before that. They ran it, they did a CT, and the radiology report literally says GDV on it. With a CT, which is insane, because that means that dog was stable this entire time, and it's just wild in some of these cases. So anyway, I do believe that there's maybe some sort of chronicity to some of these dogs. Maybe they just have chronic GI disease in general, and GDV happens later on. I don't know. But most of these cases, of course, are going to be acute or paracute cases when they present. And then, is it truly an idiopathic condition, or is there a primary source? So, for example, I've had dogs that have come in with respiratory distress with a history of laryngeal paralysis, right? But they're presenting to me in shock with a GDV. And so the question is, did that dog's aerophagia from the laryngeal paralysis predispose that stomach to distend and then have a volvulus? I've also had dogs that have had liver mass at the same time as the GDV. I've also had dogs that have had primary pulmonary mass along with the GDV. Did these things affect the ability to inflate the lungs fully? Did these things cause pressure in the diaphragm, causing respiratory change, and then that caused aerophagia, gastric distension, volvulus? I don't know, but I'm always skeptical when we call things idiopathic without trying to figure out in every scenario as difficult as possible was there a primary cause. I've also had dogs that have had a gingival mass with a GDV. Like, can I connect the two things? You know, maybe not. But I would urge folks, if you're able to, depending on the case and the clientele, whether or not they're willing to afford all this stuff, if you can find a primary condition and maybe connect the dots, maybe it's worth doing. But certainly most of these cases come in straightforward GDV, no other real comorbidities, or at least not any comorbidities that you can blame on causing the GDV. But I'm very curious as to whether or not in the future we'll have more studies that look at actual causes for GDV, albeit indirect causes probably, right? But it's something worth considering. So just the point is, a thorough workup as best as you can, especially because these dogs are going to be middle-aged to older. They should get some sort of screening anyway. I do perform 3-view chest radiographs on these dogs for screening, because usually you're cutting these dogs in the middle of the night, and you don't have the advantage of abdominal ultrasound to do a thorough staging, plus it's GDV anyway, so the abdomen's going to be hard to scan. But if you can have at least 3-view chest rads, blood work as your minimum database, and then in the OR. And my technicians are going to be radiographing these dogs while they're under anesthesia going into the OR. So it all happens on the way to the operating room. And lactate gets a lot of attention with these dogs, and I won't go into details. There's a ton of literature on this as well. It's all in the notes. But lactate we do use to help with prognostication. There's some correlation between lactate levels and how stable the patient is. There's a correlation between lactate levels and whether or not they have gastric necrosis at the time of surgery as well. And these things can affect the prognosis post-op. So if you have a pet owner who's kind of on the fence for whether or not they want to put their 12-year-old German Shepherd under anesthesia for a GDV, and the lactate's through the roof, and that dog maybe has gastric necrosis as dictated by the lactate, let's say, then that owner may or may not want to invest the finances and put that dog through it, because we do know that gastric necrosis does worsen the prognosis. How many folks here, if they see gastric necrosis, feel comfortable tackling it with like a partial gastrectomy or inversion technique? Yeah. For those who don't, how many folks here let the stomach be, finish the surgery, and then hope the dog does well afterwards? Yeah, I mean, I've had both scenarios myself as well. If I have a stomach that's kind of questionable, then I'll perform the entire procedure, then go back and reevaluate the stomach and see if it's lightened up a bit in its color and texture. So it kind of depends. It's a subjective thing, but it does worsen the prognosis. I mean, definitely GDVs that IPEXI that don't have gastric necrosis can do very, very well. The ones that do, they just tank. They just don't do well. And the average rotation, for what it's worth, is 180 to 270 degrees. So the pathogenesis of this disease, obviously, it affects the cardiovascular and hemodynamic system substantially. It is a multi-organ disease. It's systemic because of how paracute or acute it is, and obviously there's going to be compromise of blood flow. So that's going to affect all the surrounding organs, and the stomach does share vasculature with a lot of the surrounding organs. So in general, you end up with some level of hypertension because of the volvulus and distension. It'll compress the caudal vena cava. You will have bacteremia, so once you have pressure on the caudal vena cava, small intestinal vasculature is compromised. That allows for bacterial translocation, and it is one argument for antibiotics for cases like this, where you have a patient who, let's say the surgery is perfect, right? No contamination, no spillage, perfect surgery, but they have some level of SIRS or shock or whatever acronym you want to use. You can assume they're going to have bacterial translocation from the small intestinal tract, and there is reason to then cover them with antibiotics. So that's my argument for antibiotics in cases like this. They're already severely compromised patients, and you have the potential for bacteremia. I'm not diagnosing this with any actual test, right? This is a knowledge of the pathogenesis of this disease, that you can assume that 40% of these cases will have some level of sepsis. Portal vein gets then compromised, which then affects the liver, and there's another risk factor for bacteremia and pancreatitis. It can be either from a vascular reason, it can be from anesthesia, it can be from manually being brought in with the stomach as is volvulus. Maybe it's the primary cause. I don't know. Maybe the dog had it on the way in, as it before it developed GDB. And then stomach compromised, 10 to 37% is the ones you worry about needing a partial gastrectomy or involution. And then the spleen, of course, can become compromised as well from blood flow and from being wrapped in the omentum. And it can rupture also, so you can have a hemoabdomen with a GDB. And then eventually coronary flow is affected, with a good number of these dogs having arrhythmias, usually ventricular arrhythmias. So it's a multi-systemic disease, or systemic disease, multi-organ, and yeah, it's part of the reasons why these cases can be really intriguing, but also very debilitating to the patient. And so, of course, time's of the essence, so you're trying to figure all this stuff out in your mind while you're working them up and getting owner permission and trying to stabilize the pets and getting the operating room ready. All this stuff's kind of happening at the same time. Clinical signs, everybody's familiar with the signs. You're looking for a dog who has a constant non-productive retching, progressive abdominal distension, and then they're becoming more and more lethargic, weak, collapsing, all that stuff. If they have a hemoabdomen, then you're going to have the weak thready pulses, you're going to have pale mucous membranes, tachycardia. So it's your standard presentation for these dogs. We won't go too much into stabilization unless you want to, of course. There's many textbooks and lots of literature on stabilizing unstable patients. But I figured, in general, we can go over some basic foundations. So, you want to pour fluids into these dogs fairly aggressively, and you want to have ideally 2 large bore catheters in them, and then gastric decompression. So with gastric decompression, there are studies that look at whether or not trocherizing the stomach is worth it, and it seems like it is worth it. I'm not a fan of it myself, because I can't imagine that with a large breed dog and a huge stomach, this tiny little thing is going to do anything for you. But it has been done, and it's in the literature, so I have to tell you about it. And of course, if you have no other option, then sure, it's probably better than nothing to do some permutation of trocherization. Obviously, the way I want that to be decompressed with an orogastric tube. And so some dogs are so obtundant on presentation that you can decompress without any anesthesia or sedation. Otherwise, you need to have some level of sedation for these dogs to be able to pass the tube successfully. And whether or not you're decompressing them before you get into the OR or when you're in the OR is, to me, personal preference. In a 24/7 multi-specialty hospital where I'm getting called in the middle of the night, my preference is blood work is done, 3-view chest X are done, blood work is done, owners agree to everything, and then when my tech comes in, we're anesthetizing the patient, we're going into radiology, 3-view chest rads in the OR, and then as I'm opening the abdomen, now my technician is passing a tube. And because the idea is that, to some degree for me, it helps me with my derotating the stomach. If the tube is providing counter pressure at the distal esophageal sphincter, it helps me be able to gauge where my hands are. I can palpate the tube with the distal esophagus, and then with the technician putting pressure with the tube, it helps me detours the stomach. And so for me, that's helpful. If you don't have that kind of, but I also have a very efficient team. If things are a bit slower with your practice, then maybe you're more likely to pass orogastric tube before surgery. You know, while you're waiting to get the owners to sign off and stuff, and you're waiting for the blood work, and maybe you're waiting for someone to help you with x-rays or whatever it may be. So it just kind of depends. Obviously, if you're detorsing the stomach, your goal with that is to help with stabilizing the patient. So you want to detours them as quickly as you can, but you have to make it match with whatever your style is and however your flow in your hospital is. So I don't know if there's any right or wrong with when to provide gastric decompression. I tend to do it intra-op when I'm starting my incision. So here are just some pictures of passing a tube. You can pre-measure it or not. I mean, the idea behind pre-measuring it obviously is that you're hoping not to perf the stomach, right? And my argument would be, if you perf the stomach and the stomach was that compromised that you can perf it from an orogastric tube, then the stomach's vasculature is compromised anyway. Like, that's the dog that needs a gastrectomy. And if you perfed it at the time of placing the tube, you're probably going into surgery soon, right? Because these aren't the type of dogs that are going to go home on medical management only. These are surgical cases. So you're either going to euthanize the dog or you're going to cut them. So, I would say the risk of gastric perforation is very low, but if it does happen while you're doing this, kind of who cares? Because you need to deal with it in surgery anyway, and it's not like you perfing the stomach now is going to kill the dog in 5 minutes, right? You're going to have time to go into the surgery and fix the problem. So I don't really care that much about pre-measuring, but if you're going to do it appropriately, you should pre-measure. But again, if the stomach is that compromised, you're going to have to deal with it anyway in surgery, or you're euthanizing the dog. Either way, it's still it has to be dealt with regardless. So I'm not sure I really care too much about it, but it doesn't take that much time to pre-measure, and then you place a tape or something like that to figure out how deep you need to go. If the dog is fairly obtundant, it's pretty unstable, and so you're worried about sedating them just yet, you want to get more fluids into them and talk to the pet owners or whatever, but you want to pass a tube, then you can place a roll of tape and have somebody hold it and pass the tube that way instead. Obviously, this relies on the dog being able to voluntarily swallow the tube, but you can get away with this if you're worried about sedating them too much. The dog is sufficiently obtundant enough that you can get away with that. So that's not a bad idea. And then you pass the tube into the esophagus, and then your assistant in the OR or preoperatively is trying to deal with the fluid coming out, all the gross smelly fluid, and then maybe pushing water back in to help for gastric lavage. Another reason why, this is kind of a side note, another reason why I like the tube in surgery, if I'm planning on passing a nasogastric tube, I will incorporate the distal end of the nasogastric tube with the distal end of the orogastric tube. So instead of fussing around in radiology with trying to pass an NG tube and the dog is sneezing and it's annoying and it keeps getting coiled up, it's easier for me if I'm already in the abdomen, then my technician can tie the nasogastric tube, the end of it to the end of this tube, pass it in the stomach, and then I can, without opening the stomach, grab the nasogastric tube, and he tied it loose enough, he or she tied it loose enough that I can unravel it in the stomach without opening the stomach. I can hold on to the distal end of that nasogastric tube, then he or she slowly passes the tube out from the dog, and now I have a perfect nasogastric tube. It's great. So you pass the nasogastric tube, through the nose, it comes out the mouth, he or she ties at the end of the orogastric tube, you pass the orogastric tube in, I grab onto the nasogastric tube in the stomach, and then the assistant pulls out the orogastric tube. And I have a perfect NG tube. It's perfect. And it's in there. But now this is during surgery, of course, you're trying to minimize anesthetic time, but if you practice with that, you can get pretty good at it. Because most of these tubes, the distal end of these tubes, have 1 or 2 small holes. And so you can kind of weave the nasogastric tube in there.
So you use both tubes?
Sorry?
You use nasogastric and oral?
So the question is, you're using both tubes, orogastric and nasogastric. If I'm planning on leaving a nasogastric tube post-op, then I'm passing a nasogastric tube. If the dog doesn't need an NG tube, I'm only using the orogastric tube for decompression. Yeah. This is not a standard procedure for every GDV. There are some GDVs, like for example, the ones that are trying to continuously bloat on me in surgery. I'll pass a nasogastric tube in the operating room and have that post-op. Because those dogs, maybe the kind of dogs are going to keep filling up with fluid, and I need to continuously decompress them post-op. I'm not worried about that. I'm not passing an NG tube in routinely. Or let's say they've been sick for a few days, they haven't eaten in a few days or something, and I'm planning on using enteral feeding, but without, through the NG tube as well, the trickle feed. So surgery, you open the abdomen, ventral midline incision, you have a severely distended stomach, and you're trying to detours, and you have to do a full abdominal explore. Once the stomach is detoured, you have the room to be able to look in the abdomen at everything else. You want to perform your exploratory. You never know what you're going to find: liver mass, adrenal gland mass, bladder stones. You know, these dogs can have whatever, gastric foreign body. And then you want to evaluate, of course, the spleen and see whether or not it's compromised. You know, when in doubt with the spleen, if it's questionable whether or not the splenic artery is thrombosed or not, or obviously if the coloration or the texture of the spleen is questionable, then I'm going to remove it. And I get permission beforehand to remove the spleen if I feel it's warranted. And I will always submit the spleen for biopsy if they can afford the biopsy cost, and especially for middle-aged older dogs. And then also I'm going to perform typically a liver biopsy at the same time if I remove the spleen. And for no reason other than the same dogs that get hemangiosarcoma, you know, in the spleen, and so then they're older, and that's all. It's a cover your ass move for these, and the people know that. The pet owners know this as well. It's just a precautionary thing. It's not mandatory to biopsy spleen and liver, but I do get permission beforehand to be able to remove the spleen, so I don't have to call them in surgery and say, hey, the spleen is messed up. It's going to cost this much. Can I remove it? Do you want a biopsy? That conversation happens beforehand. So if I need to remove the spleen, same thing with the stomach. If the stomach needs to be resected or involuted, do I have permission to do that? And you know, they say yes or no. But if I'm questioning the splenic viability, then I'm going to remove it. It's not worth, for me, not worth keeping the spleen in dogs. They're going to be, again, middle-aged to older. They don't, the splenic function for them is not as important as for people, for adult life. And if there's a risk of splenic abscess from splenitis because of vascular compromise, and I have to recut the dog in the future for a splenectomy, I'm just going to remove the spleen at that time. Or if it's, of course, if it's ruptured, you know, if there's a laceration or a tear. And then the stomach as well, you know, typically what you see with gastric necrosis, you get this weakened outpouching of the stomach. It's got a leathery texture to it, it's thin-walled, you can palpate the difference. It's discolored, it's dark colored, and so, you know, if it has those characteristics to it and the blood flow, maybe that area, if you can assess blood flow, is not pulsating well, then the chances of that stomach coming back are almost zero, and so you have to resect or involute. But if it's questionable, of just kind of like bruising of the stomach, and especially by the cardiac, you want to be able to evaluate the stomach closer to the distal esophageal sphincter. Here, maybe on this one, right here. This is the classic area where and you may miss it here. So you need to pull the stomach up towards you and look behind it, approaching the distal esophageal sphincter. And that's where most of the trauma is going to be. It's hidden back there, typically. So if it looks kind of questionable, I'm going to leave it alone, and then I'll finish the pec-C and splenectomy or whatever I'm doing, and then look at it again. And typically in those cases it'll look better. I'm finding any reason to not touch the stomach with a resection if I can. Oh, and this is just a picture of what a partial gastrectomy would look like. You don't need to get margins on them. You know, you're not removing a gastric mass, right? It's a gastric necrosis, so you're just trying to remove the part that's of concern. I do think if you remove less, the dogs tend to do better. You know. And then gastropexy. So there's plenty of different options for performing a gastropexy. So it's whatever you fancy. The notes has like the different strengths of these. It's classic information, but all different types. You know, most of us are going to perform the incisional gastropexy. How many folks here don't perform the incisional gastropexy? They perform something else. What do you use for your pexies?
No.
The belt loop? Yeah. This here? Yeah. Pretty cool. Yeah. The only one that I'm not really a fan of is the one where you incorporate it into the linea alba. That I think, I think it's unnecessary. If the dog ever needs another abdominal explore, right, now you're probably going to undo that pexy, and not to mention maybe even enter the stomach accidentally. So that's the only one that I'm not a fan of. But the rest of them, I have no reason to, I don't know. I mean, I don't know what the risk of pneumothorax is if you're incorporating the rib with it, but anyway, I assume folks who do this have done plenty of them, and I'm sure it works great. And then laparoscopy obviously is not meant for the GDV, right? This is meant for prophylactic gastropexy. So if you're going to neuter or spay them, I'm not a laparoscopic expert by any means. So I'm purely mentioning this just to remind folks to, if you feel comfortable with pexying and you have a dog that's at risk and you're going to spay or neuter them anyway, then you can, if you're comfortable, you can offer it to the pet owner and perform a prophylactic gastropexy. It's great. It'll save them thousands of dollars later on in life, and of course, the morbidity and mortality associated with GDV. So, and you know, I have yet to see a pexy fail. If I always tell pet owners, if it's going to fail, it usually fails because the patient has other issues. They have diabetes, they've got cancer, they've got hypothyroid, Cushing's, they have something else that's impacting their ability to heal. And it's not the pexy's fault, it's the surgeon's fault. So, but anyway, just a reminder that whether you're doing your routine spay or laparoscopic, you can pexy these dogs too, and this is a beautiful looking gastropexy as well, prophylactic, so that's cool. And again, you wouldn't be using scoping for a GDV, you need a full abdominal exploratory for that. How many folks here perform prophylactic gastropexies? Yeah. How many folks who perform prophylactic gastropexies do it laparoscopically? Cool, yeah. Yeah, yeah. So the length is going to be whatever you want it to be. In the books, it'll say you want to aim for 2.5 to 5 centimeters. You know, obviously dogs vary in size, so again, we're not doing too many small breed dogs, but it'd be hard to get 5 centimeters out of that. But regardless, that's what we're looking for. And it's going to be some centimeters away from the pylorus, and the mean surgical time is about 70 minutes for eupexy, but this is the ID here. So there's a couple of points to make here. You know, one is what suture do you use? I've always used Proline. I want something non-absorbable. It just gives me added security to know it's always going to be there. Plenty of surgeons I know use PDS, and so whatever you find that works. And usually it's going to be size 0. They're large breed dogs, but whatever size is appropriate, that's what you're going to do. You're not going to enter the stomach, of course. You're just incising the superficial layer of the stomach. And then typically it's easier, I think, to start the pexy at the deepest, most cranial end of the pexy, right? That's going to be the most pain in the butt to reach if you do it afterwards. So I typically start cranial and deep, and I'm placing the first row of continuous, and then I follow it up with the cranial and superficial portion of the pexy here to finish it. And what I used to do was I used to not finish my first closure until I had the second sutures already placed. That way I can maintain tension on both ends. I've had some cases where by the time I'm done the deeper portion, I start the more superficial portion. I realize my deep portion is kind of flimsy now. The tension got lost through manipulation. So I typically won't tie the deep one until I've placed the superficial one, and then I go back to the deep one, pull it again, make sure it's tight. You know, 2 separate strands of suture, right? 2 separate packs, and then I make sure it's tight for the deep portion, tie it off. Superficial portion, make sure it's tight, tie it off, and then you should have a nice looking pexy. Any questions so far about that stuff? So complications, a ton of complications, of course. It is a systemic disease that affects multiple organs. So kidney disease, disseminated intravascular coagulopathy, arrhythmias, splenic thrombosis, peritonitis, and then recurrence. So, you know, the arrhythmia thing is huge. And when you treat VPCs, when you not treat them. So in my rules were always that the VPCs on an ECG strip take up 30% or more of the strip, I'm going to treat them. And or if the dog is clinical for the VPCs, they've got thready pulses, pale gums, they're collapsing, whatever, then I treat them. So one or both those things have to happen, and then I'll treat them. It's tough because this is so variable, and how long of an ECG strip do you have are you going to take? You know, is 1 minute better than, or that much worse than a 5-minute long strip? I don't know. I mean, who has time and how much you're going to do? And you know, if you have an ability to have continuous ECG monitoring in the hospital, then great, you can keep an eye out, and so can your technicians, and it's fantastic. And you can use telediagnostics, and maybe it projects onto a TV screen in the ICU, and everybody can kind of see that dog's ECG the whole day. Great. Most of us are not going to have that, and so you're doing kind of a spot check of the ECG. So my recommendation is you're going to have continuous, hopefully, in surgery, and then post-op, during recovery, it'll be continuous. And once the dog is extubated and awake, then maybe you're doing it every 6 hours. And again, this is a 24-hour hospitalization. If you don't have ICU care or overnight care, then of course you're going to modify these instructions based on what you can do. But you want to have ECG checks post-op I would say at least QID, if not continuous, and those are my rules for treating VPCs. Are they clinical, and or is it 30% or more of the strip? Those are my rules that I've used. If I do treat them, they're typically going to receive procainamide. If they're awake enough to handle oral procainamide, then I start them on that. If they are not awake yet, then I'm going to try and control the VPCs with lidocaine, typically a bolus, to see if there's a response, and then a CRI. Or you can use injectable procainamide as well. But I think this is typically IM. I don't know. Can you give this an IV? Does anybody know? You guys ever use procainamide? Yeah, I don't know. Usually, if I get spoiled with internal medicine doctors being in the same building, so I just ask them questions like this. But in general, if they fall on those two categories, VPCs, I'm going to treat them, and depending on the scenario, I'm either going to give a lidocaine bolus and a CRI, and or start procainamide, either injectable or oral, and then when they go home, I may have them on procainamide until the incision recheck, which is going to be 10 to 14 days. I'll then do a spot check ECG at the hospital. If there's been no symptoms of VPCs at home, collapse, pale gums, out of breath, tachypnea, whatever, and there's no VPC on my spot check, I'm going to stop the procainamide from there. Is it possible they could have VPCs thereafter, undiagnosed? Absolutely, of course. That's the tricky thing about these. You tell owners that. You just have to be upfront with them and tell them, we don't know when this dog is having VPCs and just not showing any clinical signs, right? But the farther along this dog gets away from surgery, probably the less occurrence of VPCs, less likelihood of having like sudden death or something like that, right? That's the concern. You have some fatal arrhythmia and the dog just dies. That's the worry with these. Not necessarily developing congestive heart failure. This is an arrhythmia that can be sudden and they pass. That's what you're worried about with them. So those are my rough guidelines for treating VPCs with these dogs. It'd be great if they can go home with like Holter monitors, right? Get 24-hour monitoring at home, but that's not always going to be a realistic thing, and I don't think I've ever done that unless the dog is really bad cardiovascularly in the hospital and the internal medicine doctor says you need a Holter on this dog. Then we'll do it. Otherwise, I'm not doing that routinely for them. And everything else you have to just deal with, kidney injury, DIC. Splenic thrombosis, I don't know if this number comes from intraoperative identification of splenic thrombosis or from histopathology of a removed spleen, or whether it occurs post-op at some point. I don't know that, but anyway, there's a small risk of splenic thrombosis with them. And then recurrence, I'm surprised even up to 15% with surgery. I have yet to see one recur. Has anybody here seen a post-op GDV recur? Yeah. Because these are older, large breed dogs, and they're going to be compromised. It might be really obtundant pre-op and then post-op. Bronchopneumonia is a concern with these dogs. So I try to have these dogs up and moving post-op. I don't want them just laying there because they're on opioids. Maybe an opioid CRI, and they're going to be gorked out of their mind if they're on lidocaine, which is also an anesthetic. They're going to be sedated as well from that. So I want them up and moving. I want them moving. You also don't want to stress their body, so they do have VPCs or are at risk of developing VPCs. You don't want to stress the heart either, right? So I want to get them up and walking, but I don't want to stress them out. So typically it's a short walk either in the ICU area or gurneyed outside for a short walk and then gurneyed back inside and back in their cage. Some sort of movement every 4 to 6 hours, something like that, to make sure they don't develop pneumonia. And of course, it's inherently because they're coming for vomiting, right? So of course, pneumonia is a concern anyway, but I'm thinking more post-op. The incidence of issues after surgery, it's a very, very wide range, of course. It's a complex disease. A lot of dogs do survive. Obviously, with no surgery, they're going to die or recur or whatever. So this is a surgical condition. It's typically either a surgery or euthanasia. You don't really have an in-between. How they present, if they present in a comatose or obtundant fashion, then they have a much higher risk of developing issues after surgery. There is some risk of developing issues after surgery with a splenectomy. Gastric necrosis, it's awful, so that's always a higher risk with these dogs. Lactate concentrations, and this is lactate measured in a variety of ways. Either how high is it pre-op, how much did it improve with stabilization, how much is it post-op? There's so many information in your notes for that. But lactate is a very common, and there's a whole bunch of biomarkers in your notes too other things that you may or may not be realistically able to measure anyway in the hospital. But just to give you ideas, that there's lots of prognostic indicators for this disease, just a matter of what's realistic we have access to. So key points, prevention is ideal, of course, so prophylactic gastropexes are the way to go. And nowadays with the younger pet owners, obviously they can Google everything, and so they're becoming more aware of dogs that have a risk of GDV. So hopefully maybe you'll be seeing clients, if not already, that are asking for prophylactic gastropexy. I don't know, but our job is to educate folks, so it'd be great if we had more prophylactic gastropexes. Obviously acute is more common than chronic, so just again, this is just my own experience. I think there's some chronic disease, some of these dogs, but most are going to come in periacute or acute. I'm curious about primary causes, but most are considered idiopathic. Oh, towel clamp use. So for those of you who don't have like a technician or a scrub nurse or an intern or a resident who's in surgery with you, and you're doing this on your own, one technique that I've used to help me with the PEXI, I'll place a, let's see. So I'll place a towel clamp, a sharp towel clamp, and grab the abdominal wall, right? And so I'll hold that up. And so with one hand, I'm holding the towel clamp up, and then with the other hand, I'm performing the PEXI. I'm right-handed, performing the PEXI. And this helps me with retraction, to keep the abdominal wall taut, and allows for elevation of my PEXI site, and so that way all the organs that are there and trying to get in your way are less likely to do so. So you can hold the towel clamp. It's attached to the linea, right, to the abdominal wall, not the skin, the abdominal wall, and you're pulling up, and then that allows you to suture your PEXI at the same time if you don't have an assistant. So I've used that technique when I've been alone in the OR in the middle of the night. My tech is out doing something else. I'm monitoring anesthesia and doing the surgery. So sometimes you need to have hands free. But I like that technique. That'll help too. Gastric resection, if you're questionable about it, see if you can let it go. I've had some surgeons, some doctors that will see a really messed up stomach and tell the pet owner, we're not gonna touch the stomach right now. We're gonna finish the GDV. We're gonna reoperate in 2 days and take another look. And they say that some of these dogs can really turn around. Again, this is how much I hate gastric resections and how bad it is for the dogs. So I've had surgeons that do that, and whether or not you want to try that or not, obviously you have to talk to the pet owner. It's 2 anesthetic episodes, it's more money. But if that saves you on a gastric resection, great, but I'm not advocating for that. I'm just saying that others have told me they've done that with some success. So some folks do this. But the point of this is to say, if the stomach looks questionable, or you're really not sure, finish your procedure, do everything else, and go back and look at the stomach again. Whether or not you perform a splenic biopsy, and this is because you performed a splenectomy, it's not incisional biopsy, it's excisional, you're taking out the entire spleen. Whether you perform a splenic biopsy or hepatic biopsy kind of depends on you as a clinician, what you think is appropriate, the client communication, and then the finances of the owner, whether they can afford it or not. But I will perform these if the client allows me to, especially in a dog who's at risk for splenic or hepatic neoplasia, and I'm removing the spleen anyway, that I'm gonna perform both these things. And then whether or not you perform concurrent surgical procedures. So I always go back and forth with this. If you're performing a surgery, life-saving surgery, the dog's gonna die otherwise, and the dog might be compromised, do you want to have additional procedures on board at the same time under the same anesthesia? So for example, it's an intact male and you're PEXing, do you neuter them at the same time? They have bladder stones. Not clinical for it, right? They have bladder stones. You saw it on your pre-op x-rays, or you can palpate it in surgery. Do you perform cystotomy at the same time or not? How many folks here, just in general, would feel comfortable performing an elective procedure at the same time as the gastropexy? Yeah. So for me, what I'll tell pet owners, because it can be expensive, and I can see the appeal as to why they want to do that. Can you just take care of it while you're there? I can see it. And so what I tell pet owners is, I reserve the right to abandon that plan if the patient isn't tolerating it. So I'll have them sign off on the neuter, and they understand that the neuter is not my priority, the GDV is. So if I have any concerns, whether it's blood pressure, heart arrhythmias, anything like that, I have the right to abandon that plan. and they're okay with that, because my priority is the patient, your pet, and we're going to focus on the GDV for right now. So I will do it with a big asterisk saying I have the opportunity to abandon it, and that's it. So it just kind of depends on the scenario. Some GDVs go really well. It's like 15 minutes, you're done, dog is great and everything's great. Yeah, I'm okay, sure, I'll do it. Otherwise, if it's a mess, I'm going to leave it alone. But that's my take on it. And then we didn't touch too much on post-op care. So my routine post-op care is going to be, they're going to be on antibiotics. Typically it's cefazolin, injectable, perioperatively, and then oral when they can eat. They're going to be on fluids, obviously. I'm going to monitor blood pressures, if not continuous, then QID. I'm going to monitor ECGs, if not continuous, QID. And they're going to be on some sort of pain medication. I am going to walk the line of I don't want them to be too sedate. They're older dogs that are compromised. So even your standard dose of hydromorphone or buprenorphine, it's going to knock them out. And so I go really maybe a third or half dose, and then I kind of work my way up from there. Rather slowly inch my way up towards where we're all happy with the plane of analgesia rather than just gork them right off the bat. So I'm a bit careful with that. I do not put them on non-steroidal anti-inflammatories. It is still a gastric disease, and so I have no reason to. I'd rather put them on gabapentin or tramadol to go home with, or both, and I'm not using NSAIDs. I know some doctors who do, it's fine, whatever you think, but I'm not going to have NSAIDs on these dogs. And then the heart meds we talked about, whether they're going to be on lidocaine, procainamide, or not, that just sort of depends on your criteria for that. And then finally, they're going to go home with an e-collar, and it's going to be 2-week recheck and go from there. That's my standard level of care. Most of them are going to be, if it goes really, really well, they can go home the next day. For me, they're going to at least stay the night. Again, you may not have that luxury in your facility. You might have to go home the same day, which I understand. Otherwise, if your standard GDV is probably 2 to 4 days in the hospital if they're really messed up and you did splenectomy, gastric resection, all that stuff. And then the NG tube, if you do place an NG tube, I'm mainly using it just for gastric decompression post-op because I'm worried about that dog's own ability to have gastric motility post-op, and then I can use it for enteral feeding as well if I need to. Otherwise, I'm not passing an NG tube in these dogs. And yeah, that's my aftercare advice. And if you have any questions at all, this is how you can reach me, any which way. I'd be happy to go over any questions you may have. Yes?
Do you have any tricks when it's fresh kibble and it's really like cement?
In the stomach?
Yeah.
So the question is, do you have any tricks if you're trying to decompress the stomach, gastric lavage, and the kibble's really like cement? So my technician will try like they do in horses, I guess, with colic or whatever. Maybe I'm speaking out of turn, I don't know. But he'll use this thing to pump water into the stomach, and then if I'm in there already, I will kind of mush it up and then try again. I don't need the stomach completely empty, by the end of surgery. It's ideal. I want the stomach empty, but as long as it's detoursed and I peg-seat it, hopefully that kibble or whatever's left over will pass, So I'm not too worried about it, but yeah. Otherwise, I would see if you can purchase one of these things and see if you can add more water to the stomach and then break it up manually in the surgery. Yeah, but I have left food in there, kibble in there before without any issues because it's just there's too much of it or it's really annoying and the dog needs to get off the table. So my priority is just peg-seat him and get out. But that's my trick for that. Yes.
Do you change the kibble at all, or do you alter the feeding in relation to exercise and things like that?
The question is, do you alter the kibble or the feeding schedule for these dogs or manner by which they get fed post-op, and also how does it relate to exercise? Yeah, I do actually. So I take the route for these dogs, the same route I take for like laryngeal paralysis dogs. I'll tell the pet owner, let's elevate the food bowl, let's minimize the dust from the kibble by either adding water to the kibble or switching over to canned food, and then let's get them to eat slower. For the kind of dog that really wolfs down their food, let's slow it down. Either you're hand feeding them so it's slower, or you're using one of those bowls that has like a maze or whatever in it, or you can throw big toys in there into the kibble and they have to eat around the toy, things like that to help slow them down. And then I do advocate no activity after they eat. So chill out. I know your dog is excited, you just got home from work, you feed them and they want to run outside with you want to play with them, give it a minute. Feed them, maybe an hour to digest. Most of the time the contents of the stomach empty by what, 30 minutes to an hour, let's say, around that time. So, give it like an hour after meals, and then you can go for a walk or a jog or whatever it is you want to do with them. So absolutely. Yeah, I do think that lifestyle like that does play a role to some degree. My allergic paralysis technique for these dogs is just being extra safe. There's no, there are risk factors that are related to what kind of food they eat, and I think kibble was a risk factor, I can't remember. But anyway, I try to soften their food up and elevate the bowls, make them eat slower, no exercise after you eat. Yeah. Any other questions? Okay.